Suture-based fundoplication techniques during peroral endoscopic myotomy. Peroral endoscopic myotomy with fundoplication, or POMF, is a novel technique that combines natural orifice transluminal endoscopic surgery with myotomy to prevent gastroesophageal reflux disease following POM. Following peroral endoscopic myotomy, through transillumination and direct visualization, the perigastric fat and serosa overlying the gastric myotomy are carefully dissected and opened. A decompression needle is inserted through the abdominal wall to decompress the abdominal cavity during the procedure. The needle is connected to a robotic insufflator to maintain intraperitoneal pressure consistently, enhancing the intraperitoneal visibility. The fundus is grasped with forceps and retracted into the tunnel to simulate the wrap. Wrap formation is continuously monitored with a pediatric gastroscope within the stomach in the retroflex position. A wrap is satisfactory if it covers 180 degrees or more of anterior circumference without any torsion. The corresponding position of the fundic serosa is marked using a cautery-tipped knife. Following creating the wrap, the primary technique for fundoplication is through attaching the endoloop to the fundus and distal end of myotomy by clips. A through-the-scope clip is advanced down the channel and used to grasp the tip of the endoloop device. The gastroscope and endoloop catheter are then passed together into the peritoneal cavity. The endoloop is secured to the gastric fundus using clips. The proximal end of the endoloop is then fixed to the distal end of the myotomy with 4 clips, making sure that the clips are placed on the peritoneal side. The endoloop is gradually tightened while the wrap is monitored with an ultra-slim gastroscope. After deploying the loop tail is trimmed and removed through the mouth. The challenges with a loop ligating device or endoloop include difficult passage of the device alongside the gastroscope through the esophageal mucosal incision and submucosal tunnel, complexity of handling the device, and the sharp edges of the device that could wear through the mucosal lining. To overcome these issues, we decided to use endoscopic suturing, which provides better control over the procedure. In this technique, we used an over-the-scope suturing device. A double-channel gastroscope preloaded with a suturing device is advanced into the submucosal tunnel using the floating technique. Only a sterilized saline is used and the volume is limited to the minimum required for device passage, with excessive installation avoided. The suturing device is entered into the peritoneum where the marked position is located. A seromuscular bite is taken from the gastric fundus from the peritoneal side. The tissue is taken back to the serosal opening. The second seromuscular bite is taken from the distal end of the myotomy. The suture is tightened and cinched, forming an adequate wrap. The next technique is a suture-based fundoplication with helical anchoring. A forceps is placed through a therapeutic gastroscope and is used to grasp a suture with a T-tag. The scope is advanced to the stomach. An ultra-slim scope is advanced alongside the primary scope to the stomach. A pediatric forceps is advanced through the ultra-slim scope and the suture is grasped. The therapeutic scope is then advanced through the tunnel into the peritoneum, and a 19-gauge needle is used to puncture the stomach from the serosal side under endoscopic guidance. The needle is advanced to the lumen of the stomach. A forceps is advanced through the fine needle aspiration needle and used to grasp a suture from the ultra-slim scope. The suture is retrieved across the wall of the stomach into the peritoneum and the tunnel. Helical anchoring tacks are placed over the retrieved suture and they are advanced to the submucosal tunnel. 4 tacks are placed at the distal end of the myotomy in the peritoneum. The suture is cinched with the T-tag located within the gastric lumen, resulting in the formation of a fundoplication wrap. POEM-F is a technically challenging procedure, and its technical complexity is higher than standard POEM. Additionally, the lack of dedicated endoscopic instruments increases the risk of technical failure and complications. Based on the literature and our own experience, the potential risks and technical challenges of POEM-F are summarized on this slide. The novel suture-based approaches presented in this video can add the following technical challenges: difficulty advancing or positioning the device within the submucosal tunnel, use of a single suture due to technical difficulty, potentially limiting long-term durability, prolonged procedure time, and thin distal end of myotomy muscle layer, limiting suture strength. In conclusion, currently the devices used for endoscopic fundoplication after POEM through the POEM-F technique are employed off-label. Suture-based techniques provide a feasible alternative, and the development of a dedicated suturing device for this procedure warrants evaluation of long-term durability. Although current suturing devices have limitations, such as larger diameters, a dedicated suturing device for the procedure could potentially enhance the effectiveness of POEM-F.